咱足欢喜吼，会当访问到即个伫 UCLA 咧做心理医生的迄个 Walter Dunn 吼，Dan先生。Doing the therapy, talking about like talking.
Mm-hmm. Their trauma.
Their trauma, talking about their trauma, and kind of say and analyze, or just talking.
Yeah.
You guys don't really do the talking part.
Well,
put it that way. I don't know.
So as psychiatrists, we can certainly do the talking part,
yeah.
right? But you know, there's this term, you know, practice to your license or practice to your degree, right? And so even though, yes, we can do the medications and we can do the talk therapy, we're relegated to doing more medications because the psychologist can't do that, right? So everybody kind of has their own role. So when we talk about therapy for PTSD, just as an example, this is trauma-focused therapies. Mm-hmm. It's different than just kind of talk therapies. It's really about reviewing, talking about kind of what happened to you, which to some folks actually may be counterintuitive. You know, back in the day, it was about, why would you want to talk about their trauma? It's just going to make them more anxious. It's going to, you know, cause them to be more depressed or more anxious, right? But we found that's, you know, if you expose the person to the trauma in a safe setting over and over and over again, the person's fear will extinguish, meaning that they become less fearful of that experience, and they don't become as anxious. So just as an example, I don't know if you're a dog person or not, but if you are walking down the street or a friend of yours, let's say, is walking down the street and goes to pet a dog and the dog bites them. If that person is walking down the street the next day, how do you think they would feel about approaching a dog? Probably maybe very anxious, right? And probably would avoid the dog. And then over time, for some folks, they may get over that fear. But for people with PTSD, not only are they afraid of that particular dog that bit them, they start becoming afraid of any dog, right? Because it reminds them like, oh, I was bit by that brown dog. This black dog here is not the same dog, but maybe it might bite me. So that's what we call the generalization process. So that initial trauma is a brown dog bit me, but then the fear of dogs starts to generalize. And you can imagine, maybe here in West Los Angeles where everyone has a dog, that actually might be a problem because anytime you walk down the street and you see a dog, your heart might start to race, you might get very anxious, and you may stop going outside your house. So if you were to help your friend get over the fear of dogs, like what would you do? Would you tell them to avoid dogs? Or would you actually tell them to approach dogs that are not dangerous, start to pet them more, and then the fear starts to dissipate? Right? So the exposure or the therapy then would be, okay, we'll bring some dogs we know that won't bite, and you start to pet them. All right? The first 5 times, they're still probably still really anxious. Their heart's racing. They're very reticent to approach the dog. But after you do it 50 or 100 times, they'll be like, oh, okay, it was only that brown dog that bit me. All these other dogs that I see around the street, they're perfectly fine. So in the first 10 sessions or so, their anxiety is actually elevated because you're exposing them to these trauma reminders. But then your brain starts to learn, oh, okay, dogs actually aren't dangerous, or they're not as dangerous as I thought they would. I don't need to be as ramped up or hypervigilant. That's the same thing that we do with the trauma-focused therapies. We talk about what happened to them, or we have them talk about what happened to them over and over again. And that's one approach. And over time, first couple of times, it can be very distressing. Their nightmares actually get worse. Their sleep actually gets more disrupted during the first couple of weeks. But after you reach that kind of peak, the brain starts to understand or realize, oh, that memory is no longer that distressing for me, and I can think about it.
Or is threatening.
Or is threatening, right? And so now, whenever I come across something that reminds me of the trauma, I don't have to, activate all these defenses. And so then the patient starts to get less and less anxious. So as an example, a lot of times our Iraq, Afghanistan war veterans are very wary about driving in traffic, because in Afghanistan or Iraq, if a car came close to your convoy, that represented a threat, right? Perhaps an improvised explosive device. You know, they were going to attack their convoy. Here in Los Angeles, cars are close to you all the time. Now, even though their prefrontal cortex knows that, you know, I'm on the 405, cars are near me, they're not going to attack me. But that part of the brain that's responsible for that fight or flight response, your amygdala, doesn't make that distinction. It sees a car close by, this is a potential threat, heart starts to race, they start to get really anxious, right? So again, they understand cognitively through their prefrontal cortex that this is not a threat, but they can't help but feel that anxiety. If we get them, and then what they do is they actually drive away, avoid being next to cars. They avoid driving altogether, right? So the one treatment for it, what we call prolonged exposure, is actually to expose them to that trigger that would actually make them more anxious. And again, the first couple of weeks, their symptoms are getting worse, right? We have them sit in the car in traffic, cars are next to them, and we have them not avoid that trigger. But then over time, nothing bad happens, right? No cars explode, they don't get attacked. That your amygdala starts to learn, oh, being in traffic with cars close to by, at least in Los Angeles, is not a life-threatening situation. I don't need to trigger that anxiety. I don't need to cause the heart to start to race. I don't need to have them start hyperventilating. And over time, that PTSD response starts to dissipate and get more tolerable. So that is the one of the modern ways of how talk therapy works. We actually focus on the trauma, talk about the trauma, which can be very difficult to tolerate for patients. And that's actually one of the criticisms, is that yes, it can work for a large portion of patients, but some patients just cannot tolerate it. And so we need to find alternative ways to treat these traumas. But given a good therapist where you have developed good rapport, our therapists, our psychologists are very good, and so they get patients to engage in that process. It's really about getting them to believe that this will work for them once you get over that hump, right? But getting over that hump, that's the challenging part. Having them stay engaged with treatment, having them leave your therapy sessions almost feeling worse than when you first came in, right?
You know what I've been thinking? Because you're talking about when somebody has a psychiatric disorders, you have this procedure that you started with the auto treatment, pills first, and then when it becomes more serious, they go into what you call either the therapy, the talk therapy, or
the interventionals.
Interventional. It seems like a very long process. What I'm trying to say is that why they are also looking to psychedelic drugs to make it quicker?
Yeah.
Because my own family or personal experiences, it's very painful to wait through those periods.
Yep.
Very, very painful and very disruptive.
Yeah.
What do you think?
Yeah,
want to talk about it?
Absolutely. So psychedelics is a very hot topic right now, and so the two main ones that people are looking at are psilocybin, and those are derived from mushrooms, and then MDMA, also known as ecstasy. And it's important to remember that the ways we're looking at using them now are in combination with therapy. So it's actually called psychedelic-assisted psychotherapy, right? So it's not as if I give you psilocybin or MDMA and you feel better immediately. It's really in combination with, in conjunction with the therapy. So again, the mechanisms have not been fully worked out, but there's, yes, two main advantages. The how quickly patients respond, and then the durability of response, meaning that after you get your treatments, how well do you stay well for without further treatment? And that's one of those two things have really captured people's attention for the psychedelic-assisted psychotherapies. It's also important to remember it's actually not that fast, and it's not that quick. So whether it be psilocybin-assisted psychotherapy or MDMA, we're talking, they talk about, oh, these patients are better after 2 to 3 sessions, right? 2 to 3 drug sessions. Now, the way they work, at least how we're practicing or how they're looking at it in the United States, is that they actually first meet with their therapist. And it's actually not just one therapist, it's actually 2 therapists. So you have 2 therapists, 1 patient in the room, not on drug, and you're doing what we call preparatory sessions. And there's about 6 to 9 hours of preparation going on over the course of potentially 3 to 4 visits. And that's really talking to the patient about some psychoeducation, what you can expect in the drug experience. What do you want to work on? What are the things troubling you? What are the things bothering you, right? Getting them to trust you. Look, you're going to be in an altered state with 2 people that you just met. You need to be able to trust us. So that 6 to 9 hours is developing that rapport. Then you have your drug session. That drug session can be 6 to 8 hours long. So you're in a room, the patient's in a room with, again, 2 therapists. The patient's taking the drug, and then they're doing the therapy. And the therapy is what they call an inner-directed process, where it's really coming from the patient, right? It doesn't look like our traditional cognitive behavioral therapies where the therapist is making a lot of interpretations or suggestions. It's really about what's coming up for the patient, and then talking about that. And again, that goes on for like 6 to 8 hours. And after the drug session's done, the following day or the following couple of days, they have what are called the integration sessions. Again, with 2 therapists, you're talking about what came up for you during the drug session. What were you thinking about? How did you see things differently than you normally do, right? So by that time, you're having about maybe 2 to 3 integration sessions. And that's all. So you've got your preparatory, you've got your drug, and you got your integration. And then you do the drug session again, maybe in a week or maybe a month. And again, that's followed by more integration sessions. So by the time you're done with all this, you've had about 30 to 40 hours of therapy, right? 30 to 40 hours of therapy over the course of maybe 2 to 3 months. Now, people are feeling better generally after that first drug session. But again, that's potentially a couple weeks into the whole process. So it's not really that fast per se. There's a lot of elements going into it. But the one thing that's very interesting is that after these people or these patients do like 2 or 3 of these sessions and they've completed the course of treatment, there's good evidence that even if they don't do anything else afterwards, that they're staying well for up to like 6 to 9 months, which for our disorders, all our psychiatric disorders are pretty much chronic conditions, or they can be for a lot of folks, meaning that yes, I can get you better on the drug, but you may have to continue taking this drug for the rest of your life, potentially for a portion of the population. So it's not as if, it's not like an infection where you take your antibiotic, you get better, you finish your 10-day course, and you're done, right? For a lot of the folks, at least that I see, a lot of these folks with chronic conditions, they need to continue to take medications afterwards to stay well. But for the psychedelics, after that, 2 to 3 drug sessions, they don't do anything else afterwards, and they're still doing well 6 to 9 months out. And generally, the psychedelics are also reserved for people with more treatment refractory conditions. These aren't, the field is not ready to necessarily offer these as first-line treatments because as they're very resource intensive, right? You're not only working with one, you have 2 therapists for 40 hours, right? And the type of kind of support structure needed is significant. So these, at least when they're first rolled out or approved, are going to be for these treatment refractory cases where you've done regular therapy, you've taken the regular drugs, they haven't worked, you're still very symptomatic, and then maybe let's try something like a psychedelic-assisted psychotherapy. So that's the current model that most of the trials are working under. You may have heard of microdosing, which is taking very small doses of psilocybin on a daily basis, almost as you take a medication, right? That is not done in conjunction with psychotherapy. It's just as a drug. There's not a lot of good evidence, published evidence for that, but a lot of anecdotal evidence that people can feel better doing that. But that's also not instantaneous, right? It does take time for those things to kick in. But yes, that's a major frustration in the field in that it does take time for these things to kick in. But then if the physician is on top of the case, for my patients with depression, for example, I'm not waiting a full 6 to 8 weeks if the medication's not working to try something else, right? I know by week 2 or week 3, if there's no difference at all, that if I wait another 4 weeks, it's probably not going to work. So I'm moving on to something else, right? But yes, that can be still very frustrating for patients and their families, is that you're doing trial after trial after trial, right? And finally, maybe you get to something that works. But that's due to our lack of understanding and of the illness, number one, and we don't really have good tools to predict which treatments would work best for certain people.
Marijuana is legalized. Do you guys use marijuana as a part of treatment at all?
Yeah.
I'm just curious.
Sure.
You never mentioned anything about anything on that.
Yeah.
I was just curious.
Yeah, so the VA, of course, is a federal institution, and federally, marijuana is still illegal, right? And so we cannot prescribe marijuana. We cannot recommend marijuana.
At the VA
at the VA hospital, we cannot do that. Yeah.
But
so
at the UCLA, it's okay.
UCLA is technically okay, but that's not something that actually, at least in my practice, that I necessarily recommend. And that's for a couple of reasons. That's not to say that marijuana cannot help certain folks, right? But I'm coming from, my research background is for patients with psychotic disorders. And so in the schizophrenia clinic, unfortunately, I see cases where marijuana has either triggered or exacerbated the psychosis. And so that's why I am always very reticent about pushing or recommending marijuana.
Oh, you know what? Maybe I have been reading the wrong literature. Whatever I read, they were just saying that regular use of marijuana, we're not talking about heavy dose. They say actually it's pretty harmless. I know what you just told me is different.
Sure.
From what I read, so I was kind of surprised to hear that.
So just kind of generally, nothing is harmless, right? Nothing's harmless. Everything that we do has a cost, right?
Alcohol.
Yeah, every medication that we prescribe has a potential downside. So nothing is without cost. Now it's really about kind of what the cost is, if we're willing to bear that risk, and the risk is different depending on different populations.
You mean it can trigger schizophrenia?
Yeah, so very good question. So in a regular person without any family history of any psychotic disorders, the use of marijuana will probably not result in any psychotic symptoms, right? But if you have a brother or sister or aunt or uncle, right, with actually bipolar or schizophrenia, you probably have some genes that may predispose you to having psychosis, right? So now there's no guarantee that you'll have schizophrenia, but you probably want to avoid anything that may precipitate psychosis. Cannabis being one of them. So again, in the schizophrenia clinic, we are dealing with folks who have a diagnosis of schizophrenia already. Unfortunately, a lot of folks will continue to use cannabis despite that diagnosis, and that will make their psychosis worse. And so that's why I'm not a huge proponent of it. Again, in certain situations, certain indications, certain populations, at certain doses, potentially cannabis may be helpful. But in the folks that I see, and just kind of from my background, I'm not seeing folks where it may be actually helpful. It actually potentially could be harmful. And the other thing to remember is that today's cannabis is very different from your parents' cannabis, right? It's much higher in what we call THC content.
Really?
So yeah, so
Much higher THC?
much higher THC content. So THC, of course, is this psychoactive component that gives people the high. Probably back in the 60s or 70s, it was maybe like 10 or 15%.
When you say it's higher, it's because right now it's the extract of it.
Well,
or they were just using the
plant.
The plant.
So actually, not only the extract, but also they are breeding the plants to have higher THC content. So it's not unusual to be, even if you have the plant, that you're up to like 30 to 40% THC content. So they're manipulating the plants specifically to get a higher THC content.
So you need to know the dosage, but it's not FDA regulated at all.
No, it's not FDA regulated. And so that's another thing that makes me hesitant to recommend it, because you don't know what you're getting. So you can go to your dispensary. They may tell you that this thing has 30% THC. There is no guarantee, right? There's absolutely no guarantee. So for all those reasons, I'm not a prescriber or I do not recommend cannabis.
He doesn't want to say anything. But, I think the last topic we want to get into is is regarding Taiwanese American community that I heard a lot of, enough the cases I heard, when the kids reach to maybe 18 or 19, they start showing the symptoms, either anxiety or depression or suicidal thought, and some actually end up not really well. What I'm trying to ask you is, like, from your understanding of the Asian community, what would be your advice?
Yeah, that's an outstanding question. And it's a really important question because this is really about the future, right, of our community, right? These are our youngest, next generation folks that we really want to ensure they have the best opportunities at life, right? So, mental health, I think, in just beyond just Asian communities is not widely talked about. In fact, when I was thinking of becoming a psychiatrist, my mom said, "Are you sure you don't want to be a surgeon? Are you sure you want to be a psychiatrist?" I was like, "Yeah, I want to be a psychiatrist." She's like, "Okay, fine." But that's not something that, again, in mental health is widely talked about, and not just Asian communities, right? It's still a very large stigma surrounding talking about mental health. I think what my recommendation, or the way I like to couch it to folks, or to kind of sell it to folks, is that, look, this is conditions like bipolar disorder, depression, anxiety, schizophrenia. This is a brain disease. No different than diabetes or heart disease or hypertension, right? Your brain is an organ just like your heart. Your brain is an organ just like your kidneys, right? It's a much more complex organ, right? One way we do not understand as well, right? And I think part of that lack of understanding or misunderstanding about where these illnesses come from contributes to that stigma, right? So I would say that number one, think of these symptoms, conditions as no different than a quote unquote medical condition. Unfortunately, we still talk about medical conditions and like psychiatric conditions, right? They're only relegated as psychiatric conditions because we don't know what the cause is, right? And the other thing is that, look, this is the most complex organ that we have, right? And it's not surprising that it can misfire or not function as well. If you've got a very simple machine with not a lot of parts, yeah, it works very reliably day to day. But when you've got like something very complex, there's so many different parts that can go wrong, right? And that's just the nature of it. That's just the nature of the organ. And how it presents it can be very confusing, right? Depression, anxiety, and it's not a sign of weakness, right? I think there's a concern that, oh, this is weakness, right? And if you ignore an injury, does it make it go away? No. In fact, it probably makes it worse, right? You want to address it. And so, the conversation I have is, look, if you have an injury, if you have something that's wrong, you want to seek out help so that they can be the best version of themselves possible. Ignoring the problem, shaming it, that doesn't make the problem go away. In fact, it probably makes the problem worse. And so it really takes courage to say, number one, I have these symptoms, right? And number two, to seek out help for it. Because it really is about, again, for our youngest and most vulnerable folks, it's about setting them in a path of life where they can have the best chance of succeeding. And the way our society is built is that we rely heavily on what our brains can or cannot do, right? And the emotional aspect of our brains is a very important part of us, right? This is not something that we can't wish away or ignore our depression or anxiety. This is an integral part of us. This is an integral part of how our brain works. And there's no way to push it aside. Because yes, it can cause problems at some points, but it is also essentially who we are. And the fact that your kids are able to have a loving relationship, or you're able to have a loving relationship with your kids, is because of that part of your brain, right? But sometimes, you take the good with the bad, right? There's always a other side of the coin. And we have to nurture that entire that entire sphere of both those sides in order for us to be complete and healthy human beings. And this is not a conversation that, again, is had and then suddenly they change their mind. It's something that's kind of repeated over and over again. But we can be models for for our patients, right? There needs to be initiatives in the community to say, hey, look, talking about this is not a sign of weakness. This is something that people need help for. I don't think the Asian community tries to hide the fact they have hypertension or diabetes. I think they talk about, I'm on this hypertension medication. It works really well. I'm on this, right? Oh, I'm not eating as much rice so that my hemoglobin A1C is not so high, right? We need to be able to have the conversation one day. I'm exercising every day. I'm meditating every day, so my depression doesn't, relapse to occur again. I'm talking to my therapist on a weekly basis, so my PTSD doesn't cause me to isolate from my friends and not go out and interact, right? So.
Well, actually, when you just saying that, it just triggers something, because I think a lot of kids don't listen to their parents. So if their parents say go see a doctor, they say, oh, the heck they do, So what I'm trying to say, actually, the high school may be a good place to start.
Yeah.
Before they get into the situation.
Yeah, absolutely.
Somebody talk about the mental health,
Mm-hmm.
right? So the last thing, how do you maintain your mental health? What do you do?
Yeah.
What do you do to make you feel?
Yeah, that's a good.
Because you're a busy person. You have so many responsibilities, so much work.
Yeah, absolutely. Yeah, that's oftentimes physicians are their worst patients, right? Because they never follow what we tell our patients to do, right? Do what I say, not what I do, right? But yes, exercise is a big thing, right? Exercise is a big thing. Yoga. There's a very meditative quality to it, but just regular exercise. Jumping on the spin bike for 20 minutes every day, doing my push-ups, doing my sit-ups, walking around the block, getting the sunlight, not ensuring that I'm not sitting in a dark office all the time, right? Getting out into nature. You can see around here in the backyard we have a lot of greenery, right? And that is a very calming aspect of it. Spending time with my family. Right, making sure I have time for my daughter, for my wife, for my parents. Right, those are your sources of strength, and it's really about again making time and understanding that, at least from my perspective, is ensuring that I'm the best version of myself, so that I can do all engage or fulfill all these responsibilities that I have. It's a lot of work. I do have fun. Right, but again, I need to be on the top of my game, at the top of my game, to do all these things, and also being, recognizing when certain aspects of your job are either fun for you or not, right? So even though it doesn't sound like I say no to a lot of things, because I have a lot of things to do, if there are certain things I know will cause me undue stress, or if the risks or the benefits don't outweigh the risks, I'll say, what, this is probably not good for my mental health, right? So yes, it's an ongoing thing as well, right? It's not like you do one thing and it solves the problem. It's really about maintenance, kind of keeping up, right? But those are just some of the things that I like to do. And of course, sleep. Sleep's a big one too. Sleep. I have to kind of tell myself, look, I know I got a lot of things to do. I'm not finished with them, but I need I need to allow myself my 7 or 8 hours of sleep, right? So the basics, right? Exercise, good diet, and sleep. I tell my daughter, what are the 3 things that you need to do to grow up strong and healthy, right? It's sleep, exercise, and eat well. And of course, my dad also added to be happy. It's like, yes, absolutely.